Okay, so hello everybody. I'm Ken, one of the cardiology registrars. So I've been working with the eMERGE team since 2017, I think, on a series of studies looking at how we could use CT coronary angiography in patients who are discharged from the ED after myocardial infarction has been excluded. And so the first of these studies is our prospective observational study called PRECISE-CTCA. And this has led on to our ongoing trial called Target-CTCA, which some of you might have come across already. So the first thing I want to say is, I think this has been a fabulous collaborative effort. And I think it gives me a great pleasure to come back and share the findings of this study to our group. So as many of you are well aware, high sensitivity cardiac troponin has significantly changed the way we diagnose and risk stratify patients with chest pain in the ED. Major improvements in assay precision now permit accurate quantification of troponin at very, very low levels. And this has led to progressive lowering of the diagnostic threshold. Next slide. Such that we are now able to measure troponin in everyone. And this has made it a really interesting area for research, but I appreciate it's made life a little more challenging in clinical practice in terms of actually figuring out what's going on with the patients. So some of you may be aware with the older generation of troponin assays that not too long ago, we used to have to admit almost everybody with suspected acute coronary syndrome just for a 6-hour or 12-hour serial troponin measurement. But one of the major innovations with high sensitivity troponin assays is that it's enabled the development of early rule-out pathways for myocardial infarction. And this is our high-stakes pathway that we introduced across Scotland as part of the pragmatic trial called Historic Trial. And the idea behind this is that patients with very low troponin concentration at presentation are at very low risk. And we can exclude myocardial infarction with a high degree of confidence. So these patients can be discharged directly from the ED without having to undergo serial troponin measurement. And those with troponins above the 99 centile are admitted for peak testing. So that's the patients in the rate zone. Those with intermediate concentrations are retested and only admitted if the troponin concentrations are rising by 3 or more at 3 hours. Nick, you want to go back to that slide?
I think we've got a problem with the delay where...
I see. Apologies. I think that it's probably my internet connection. So I apologize for that. So those with intermediate concentrations are retested, and they are only admitted if troponins are rising by 3 or more. So ultimately, the majority of patients can be discharged from the ED, and only about a quarter of patients have to be admitted for further investigation. And the historic trial showed that implementation of this early rule-out pathway was safe and significantly reduced length of hospital stay and increased quite significantly the proportion of patients that we can discharge directly from the ED. Next slide. However, from our data, so this is the high-6 data, it is apparent that even after we've excluded myocardial infarction, these patients are still at risk of future adverse cardiac events. Those with peak troponin concentrations in the intermediate range, so that's the blue line in this cumulative incidence plot. So they have a 5 to 10 times higher risk of myocardial infarction and cardiac death compared to those with very low concentrations below 5. But the optimal approach to investigate or manage these patients is unclear. So at present, in our clinical practice, most patients are discharged home without any further investigations or follow-up unless they give a clear history of anginal symptoms. So a recent trial conducted in Australia, this is the RAPID TNT trial, reported some really interesting findings. So this trial evaluated the implementation of the 0-1 hour pathway recommended by the European Society of Cardiology. Those So how can we use cardiac troponin to help us manage these patients? So there's been a number of observational studies suggesting that very low levels of troponin, well below the 99th centile, reflect a range of key pathological processes. These levels have been shown to be increased with reversible myocardial ischemia, and they're also related to plaque burden and plaque vulnerability. And they're also strongly associated with cardiac fibrosis, which is the final pathway of myocardial injury. So how can we translate this interesting observations into better patient care? So in PRECISE-CTCA, we would like to evaluate whether cardiac troponin can be used to improve the way we select patients who've had myocardial infarction ruled out for further downstream testing. So the next question is, what modality should we use for downstream investigations? So we've gained some insights from the SCOT-HEART trial, which has demonstrated how we might use troponin in combination with CT coronary angiography. So the SCOT-HEART trial was a multi-center randomized controlled trial of CTCA versus standard care. And the standard care consists mainly of exercise tolerance tests. And they recruited over 4,000 patients with possible angina across hospitals in Scotland. And in a sub-study of around 1,000 patients randomized to CT, we performed additional biomarker testing. So we measured cardiac troponin in these patients using the Singulax platform. So in this trial, CT coronary angiography improved the certainty of diagnosis, and also it was associated with an increase in diagnosis of coronary disease. And this led to a significant reduction in fatal and non-fatal myocardial infarction at 5 years. And in the sub-study that I was referring to earlier, we found a strong association between cardiac troponin and the Eggleston calcium score, which is a surrogate marker for plaque burden, coronary plaque burden. And likewise, there was a 5-fold increase in the presence of obstructive coronary disease across quintiles of troponin concentrations. So this is some recent data that was published from the ischemia trial just last week in Circulation, actually, which I think further strengthens the rationale for using anatomic testing using CT coronary angiography. So this is the expensive North American trial that enrolled over 5,000 patients with stable coronary disease. And they found no difference between an initial invasive management plan versus conservative management of these patients with coronary disease. And all patients in this trial underwent both anatomic testing using CT coronary angiography and ischemia testing using a range of different ischemia tests, treadmill ETT, stress echo, stress MR, nuclear imaging. And what they found is really interesting. So this forest plot shows the relationship between severity of ischemia and their primary and secondary outcomes. And I think it's fairly evident here that there seemed to be no association between severity of ischemia and prognosis. What you see on that forest plot is as you go from single vessel disease to 2-vessel disease, 3-vessel disease, you can see a clear gradient in risk, in future risk. So I think this new piece of information, I think, further supports the use of CT coronary angiography over other diagnostic modalities. So in PRECISE-CTCA, we aim to look at the association between high sensitivity cardiac troponin and coronary disease in patients who presented with suspected ACS in the ED and troponin concentrations below the 99th centile. And so this would be a useful piece of information to help us decide whether this approach to combine troponin and CT could help us diagnose and manage these patients better. So this is so PRECISE-CTCA is a single center prospective cohort study. We recruited a total of 250 patients who presented to our ED at the Royal with suspected acute coronary syndrome with a peak troponin concentration of less than the 99th centile threshold that have been evaluated using the high stakes protocol. And these patients are recruited in a 2-to-1 ratio stratified by the 500 grams per liter threshold. So that's a third of patients with troponin concentrations less than 5, and 2/3 of patients with intermediate troponin concentration between 5 and the 99th centile. And we excluded those with a clear alternative diagnosis. For example, if they've come in with some chest pain, but subsequently found to have pneumonia, for example, then there's a clear diagnosis there. So these patients were not recruited. And we also excluded those with clear contraindications to CT, such as severe renal failure, pregnant women, or those with severe allergies to contrast. So this is our baseline characteristics of study population, stratified by those with very low troponin concentrations and those with intermediate troponin. And those with troponins less than 5 were younger. And they also had a lower comorbidity burden with less diabetes, hypertension, or previous known coronary disease. So this should show the forest plot of our CTCA findings. So what did we find when we scanned these patients? So compared to patients with troponin less than 5, those with intermediate troponin concentrations had 3 times higher odds of having any coronary disease on CT. And they also had a higher prevalence of obstructive coronary disease, although this was not statistically significant, likely because we lack the statistical power. But interestingly, when we then substratify whether or not these patients presented with anginal symptoms, there did not seem to be any difference whatsoever in the prevalence of coronary disease, whether this is any coronary disease or obstructive coronary disease. And I think these findings are quite provocative, and it raises a question as to whether we should continue to rely purely on patients' description of their symptoms, or whether we should use a more objective test, such as cardiac troponin, to decide those who are more likely to benefit from further downstream investigation or follow-up. So this is a cumulative incidence plot across troponin concentrations in the normal reference range. So as you can see, we found a doubling of the prevalence of coronary disease from the limit of detection up to 16 nanograms per liter, and also a similar association is found for obstructive coronary disease as well. So this should show a bar plot. There's quite a lot of information here, but basically what I'm trying to do here is to tease out how we can use this additional information from CT to help improve the diagnosis and management of these patients. So the blue and red bars represent those with any coronary disease or obstructive disease identified on CT. And the dark shade on the bottom are those with prior diagnosis of coronary disease. And the lighter shade on top are those with no prior diagnosis. So the majority of patients that we've identified who have disease on CT are new diagnosis. And so these are the patients I think would benefit most from preventative medical therapy, such as an aspirin or a statin. Now, these are the same bar plots, but now the shades represent the preventative therapies that they were on prior to receiving the study CT. So darker shade on the bottom shows those who are already on an antiplatelet and a statin, and on top, those with no preventative therapies. And it is apparent that most patients were not on optimal preventive medical therapy, suggesting that there is an opportunity here to intervene and to hopefully make an impact on their management and subsequent outcomes. So in conclusion, we found in PRECISE-CTCA that patients who've had myocardial infarction ruled out, those with troponin concentrations in the intermediate zone had 3 times higher odds of having coronary disease on CT compared to those with low troponin concentrations. And interestingly, the presence of anginal symptoms did not discriminate between those with or without coronary disease. And most patients with coronary disease identified on CT did not have a prior diagnosis and were not on optimal preventive medical therapy, suggesting an opportunity here to intervene and improve outcomes. So obviously, PRECISE-CTCA is a small observational study. So while these observations are interesting, we now need to demonstrate whether this approach of combining troponin and CT could actually result in meaningful improvement in patient outcomes. And this is what we are evaluating in our ongoing multi-center trial, Target CTCA trial. And here we are recruiting patients with intermediate troponin concentrations and randomizing them to CT coronary angiography versus standard care. We're currently just over halfway through patient recruitment, so hopefully it won't be too long before I can come back to this meeting to tell you what it shows. So I just want to thank everybody who's contributed to this fabulous effort over the past few years. And the eMERGE team, of course, CVS Biomarker Lab, colleagues in Edinburgh Imaging. I think that the fact that we've been able to deliver this individual patient recruitment study despite challenges with the pandemic is a fantastic achievement in itself. And I'm also pleased to let you know that our manuscript for PRECISE has been accepted for publication in JAC. And I think it would go live the first week of October. So if you're interested, please have a look at our full manuscript. And thank you very much for listening. Happy to take any questions.